Brian.
Good morning, Angela. Can you hear me all right?
Yep, sounds good.
Okay. So will you display the slides?
Yeah, I can display these slides.
Okay.
Looks like Gary will have his.
Right.
Yeah, thanks so much for doing the intro. I think that'll be good.
Yeah, no, that's fine. I just had a paragraph about Gary. I was just going to introduce Gary. I was going to say welcome to BIRCH workshop, but I didn't have a slide prepared for like explaining BIRCH, which is probably a fine idea.
Yeah, I think just a way to get us out a little bit more since
Sure, absolutely.
Yeah.
Absolutely. Where was that? Good. Methods consultations.
Yeah.
I mean, the JIG quant is not open to like all these attendees. And so that was, I wasn't sure.
Okay.
But we can have it. And if somebody was interested and.
Yeah, I think you can specify that, some of these are only.
No, we can just put it up. And I mean, if somebody emails me, I'm probably not going to say no, but I guess, I'm not expecting, I don't know. Yeah, it's fine. I think it'll be fine. Workshops, okay. And yeah. So yeah, no, thank you.
Okay, yeah. And hopefully Gary's able to join. It'd be nice to be able to test him sharing his slides and make sure.
Yeah, I have a feeling Gary's been doing a ton on Zoom for a long time, and so I bet it'll work pretty well. Yeah, it's going to be hard to sit still for 3 hours, so I might turn the screen off and move around a little bit.
Yeah. This is weird. Someone is joining as me, and I don't know who this is.
Huh.
Hi, you just joined?
Hi, this is Gary. So,
oh, hi.
You're mislabeled.
Yeah, that's very strange. Let me change your name. I think I can do that.
Yeah, I just wonder maybe every participant would be called Angela.
Okay, there you go. A second. Hopefully that doesn't happen to other people. That will be very confusing.
Yeah, I just clicked the link, so I don't know.
Oh, that'd be interesting.
Yeah.
My grandmother once went to a meeting of people named Polly.
Oh, of everyone with the same name.
Everyone there named Polly.
That's so funny. Okay, so I think we're all co-hosts now. Awesome. And so, yeah, we should be good. I know, Gary, if you wanted to test sharing your slides at all, you probably know how to do that, but
yeah, let me I have to open too many windows. I have to find it. So can you see the slide?
yeah, it looks great.
Okay, so let me see. This should be full screen, right?
Yep.
Do you see it's moving?
Mm-hmm.
Yeah, it looks very good.
Yeah, it looks great.
Okay, then that's good. Yeah. Yeah, sometimes it's just like they'll stay at the first screen. So at least it's working great. Yeah.
So yeah, I'll start with sharing my slides and then and then I'll turn it over to you. That's what we have to start out with. But
sure, yeah, thank you. Yeah, I'll have it like 2 sessions. So each of them will only about an hour. Yeah. And I'll yeah, hopefully there will be some Q&A. Yeah.
And yeah, I guess like I emailed about, I included in my agenda, I put in like a break, and these times are approximate. I'll say that they're like approximate. But does that kind of line up with when you were thinking of having your break with the hour?
Yeah. I think about yeah. Maybe we could finish a little bit earlier, but I think this is
Okay.
good. Yeah.
Okay, great. Perfect.
Great. Thank you, Gary.
Yeah, you're welcome. So are you teaching in the fall quarter? No, okay.
Now, this is my BIRCH related buyout is this quarter.
Oh, okay. That is good. Yeah. So well, I guess so who is teaching your like usual classes then?
Yeah, no, that's kind of the thing in my department. Almost no one picks up many of the classes that I don't teach. People just go to other areas in the university like CSSS or sociology.
I see, okay.
But
I see.
yeah, my last chair wouldn't let me buy out of my priority class. So we have a priority class and then we have 3 non-priority classes. And usually people are allowed to buy out of their priority class because it's usually the most work. But because it's so hard getting people to cover regression in my department, they don't, my last chair wouldn't let me. So I stopped fighting. So I just teach regression every winter. And I don't teach kind of more advanced classes. I might, I haven't actually for a few years. I've had enough grant money to buy out of my 2 kind of regular electives. And then I don't have, so I actually have a really low teaching load, which is fine for research, but the grad students are unhappy.
Yes, I can definitely understand. But I mean, I guess there might be other, well, say item response theory class in the United States.
So Chun Wang, who actually I think was on the list of attendees for today's session, she's the MPARC recipient. Chun.
Yeah.
She teaches. I mean, that's her area. She's an IRT superstar. So, and she's in EdPsych, College of Education and EdPsych. And so she's teaching if you have students who are interested in IRT, she's teaching IRT. I think she has a 2-class IRT sequence, and I think she's teaching the first quarter this fall. Yeah, and then they hired someone recently in EdPsych, Oscar. I'm forgetting his last name, but Oscar is the gentleman's first name. And he's been teaching a 2-quarter structural equation modeling, confirmatory factor analysis sequence.
So also from
EdPsych, yeah. EdPsych's doing a much better job of covering this stuff than my department is.
Interesting. Wow.
So. Well, we start in 5 minutes. I'm going to walk around a little bit and do a couple things for a couple minutes before we start.
Okay,
Just
sure. Yeah, no worries.
I'm going to be sitting for a bit. So I might turn my screen off every now and then, Gary, to move around a little, but I'll still be listening.
Yeah. No worries.
So one of the things that I'm interested in thinking about while you're presenting is in almost all latent variable models, the predictor is the latent variable. And the response is the item. And I think there's a lot of room to think about confounding and non-random missingness, kind of in the measurement model stuff. And that seems related to the topics you'll be talking about. So
yeah. What I'm going to talk about is just, well, I guess the simplest situation, but you can
sure. Sure. That's fine.
Yeah, complexity, that definitely, different kinds of outcomes, to do that.
Right.
Yeah.
Right. All right. I'll see you in a couple minutes.
Sure. Yeah, I'll also get a cup of water.
Yeah, sounds good.
Oh, so we've got 14 people in the waiting room and, 14 people. Do you want to, I think we could probably,
Yeah,
we can give it one more minute or just get started.
Yeah, I think we can admit them. Yeah.
Okay, great. Give me just a second to share my screen and get everything settled. Okay. Sorry, I can't find the waiting room to let people in. Maybe I'll just admit everyone and then share my screen. Great.
I don't see them on my participant list.
So they're still in the waiting room. I'll just admit everyone right now. Or can I? Sorry, I just want to figure out how to do this right.
No, no problem.
Here we go. Got it.
But since I don't see them, that means I can't watch it to let people in.
Oh, okay. I can keep an eye on. Yeah, I'll keep an eye on it. Okay. Good morning, everyone. Thank you all for joining our UW BIRCH Methods Core workshop bright and early. We are going to get started. I'm Angela Marler. I'm the program manager for UW BIRCH. And I will just go over a couple logistics and our agenda before we start the actual workshop. So for our agenda today, we're just going to have some logistics. And then I will turn it over to Brian Flaherty, our Methods Core Director, and he'll introduce our Methods Core as well as our presenter today. After that, we'll get into our workshop. We will have a 10-minute break in the middle. I know this is a long workshop, and so we'll build some time in for a break, and then we'll wrap up by 12. So for some logistics, today this meeting is being recorded. We will post it on our YouTube channel, and we can share the link with you after that's been posted as well. There will be some designated times for Q&A during the workshop, but if you have some questions outside of that time, just write them in the chat box and we'll be monitoring that. And lastly, we will be sending out an evaluation form after the workshop, and so we would love it if you could fill that out and share your feedback with us. With that, I'll turn it over to Brian.
Thank you, Angela. Good morning, everyone. I'm Brian Flaherty. And this is just a little information. BIRCH is a developmental research center, NIMH funded, and the Methods Core, well, I guess let me say, so it's focused on integrated care of HIV and mental health, how to understand those dynamics, how to model them from a methods point of view, but also how to change and improve the health of people with mental health and HIV risk and challenges. Can you go to the next slide, Angela? The Methods Core, it's myself and these are the members. Gary, our presenter today, is Associate Director. And David Hu is a research professor in social work. Changzi Di is research faculty at Fred Hutch, and Brian Weiner is in global health implementation science. And Sarah Holte is in the CFAR biometrics core. She is serving as an advisor. Next slide, please, Angela. So the methods core has some core foci, and we have a junior investigator group that we're trying to build and foster, providing methods broadly, consulting, information, discussion, troubleshooting, etc. The BIRCH core, methods core, does offer consulting for BIRCH members about HIV, mental health, again, broadly defined. And then we're doing workshops and seminars like this one. Linda Collins will be here October 24th and 25th. Her talk will be the 25th in the morning. And we also do have a pilot award every other year, a pilot award, like a seed grant, but methods focused. So that's a quick overview or introduction to BIRCH and the methods core. Could you go to the next slide, please? And so our presenter today is Gary Chan, professor in biostatistics and health systems and population health, among others. If you look at his website, he actually has multiple affiliations. He got his PhD in biostats from Johns Hopkins, and as the text here notes, he's a fellow of the American Statistical Association and Institute of Mathematical Stats. And his primary research interest is in methods for observational and complex designs and complex mechanisms. So with that, I'll just turn it over to Gary.
Yeah, thank you, Brian, for the introduction, and I'll start sharing my slides. I have to find it, open too many windows. Okay, what's there? Okay, so can you see my slides? Is it moving? Okay, so I don't. Okay, I guess it's working. So thanks, thank you everyone for joining. So as Brian mentioned, this is a BIRCH workshop. We have well, BIRCH is the it is a P30 that's we actually have a lot of different faculties from different backgrounds and also trainees from different backgrounds, and we have a workshop once or twice a year on different topics. Last one was given by Jim Hughes on like the trials that's so it's longitudinal in nature. So we are so today I'm going to talk about some more of the observational studies related topics. And I know that the audience actually is from very diverse fields. I have several of my colleagues actually, faculty, in the biostat department joining, and we also have students, trainees, people with different stat backgrounds. So this, I'm trying to, hopefully, like everyone can get a little bit from the slide or from the information. So so there would probably be some fractions of it that is probably technical, but I'll also be so. I mean, some of that might just might be well, I guess it could be a little simple for some of you, but I'll try to sort of keep everything together. Okay, so well, I guess a lot of you probably have heard about causation. Association does not always imply causation. Or association does not imply causation. So some people just use this to say, well, you can't do anything with observational data. That's one view. of this, but I also put always here. So actually, association does sometimes imply causation. I mean, if you are sort of carefully thinking about the problem, so this my taking to that is like this is, well, I mean, if you're doing association studies or if you're doing observational studies, yes, you're not doing an experiment. You're not doing a randomized trial, but with some care, because you need to know how to sort of sort of make causal statement. You can make some kind of causal statement. So I'm going to ask like some questions first, things that is important to consider before I go into some of the conceptual and technical details. Right. So confounding is usually the problem. In observational studies, and we, and I guess the overarching question is then how can we make better causal statement from observational data? So then we need to know about what is confounding, and another, well, we'll sort of give you a little bit of a introduction to that. But also, like, what is lack of confounding? So, so if we don't have confounding, so what's the advantage of, say, having situations that we don't have confounding? And we are going to look at randomized trial, basically. Like randomized trial is a situation you don't have confounding, then you can actually be able to do evaluation, well, in an unbiased manner, but then we are going to dig deeper, like what that means and what can we sort of learn about from a randomized trial to observational studies. Yeah, and I hope everyone has taken some introduction level of regression classes or maybe first year graduate level epidemiology class that's talked about confounding control by regression models. So we know regression. We know, okay, we have linear regression, logistic regression, Cox regression. So like the different kinds of like regression model for different outcomes. So are we done? Because, well, this is one way of dealing with confounding control. And so the answer is that, well, it's not really, because there are other methods. And one of the common methods, I hope a lot of you probably have heard about, is called propensity score. So, well, what is propensity score then? Is it like, and how does that fit into sort of the usual regression framework? Well, the answer is that it doesn't really fit that well into the usual regression framework, so it requires like a different thinking. But then we kind of will talk about like why do we need that, and like what's the advantage, and are we trying to do the same thing, or are we doing different things? So that would be so part that we are going to be cover this morning. And and also we have to clearly define what we are interested in. I think one really nice positive impact that causal inference is bringing to science and epidemiology is that it forces us to think more carefully about what we want to estimate, what we want to compare, and what really is the parameter of interest. We have, well, when we talk about parameter in regression, it is like those betas that you get from the computer output, right? Usually, but do they have causal interpretation? What kind of interpretation they have, and also, is that sufficient? Do we need to sort of define parameters in different ways? These are sort of questions that has been asked. And I think when you are conducting studies, you also have to ask yourself, what do we want before you actually go to like the do the analysis, right? So we need to clearly define what we want. And is there a conceptual framework that helps us to formulate or define causal parameters? There's one called counterfactual outcome, potential outcomes that we are going to talk about. And through that, it is a conceptual framework. Because things are counterfactual, it is not really, it does. But it does some nice, I guess, it has some nice properties, and it also has some sort of nice way that we can use to define or to use to to study the causal parameter. Things like how do we sort of formally define no unmeasured confounding, right? So we always talk about, oh, if you adjust for enough confounders, then then your estimate would have causal interpretation. So those are like qualitative statement, but how can you actually make it so precise? And potential outcomes frameworks actually is one that actually helps you to sort of think about what those assumptions really means. And of course, like when is like those parameters of interest estimable from data. So when we want to make those statements, then and you want to use whatever data you have in order to make some causal statements, but then you have to know what kind of assumptions you need. Okay. And one thing that you also have to consider is that actually who is relevant. It's related to your definition of the parameter of interest. One thing that I'm going to talk about quite a lot today is called it's just called average causal effects. The average causal effect is actually not always the parameter of interest that you are interested or you might be interested in, because first of all, your study sample is it representative to the population of interest. So if your study sample is just a convenience sample, you can still talk about the average causal effect, like in a convenience sample, but that might not be sort of generalizable, to say broader population. Versus you might have some better designs, like say if you do like a population sampling, or although it's seldom, but say if you can do random sampling, right? And a lot of these studies, if it is sort of collecting data in a cohort, it might be like in a stratified sample. So if you have some different samples which have different subpopulation characteristics, basically just different distribution of the baseline characteristics, you are going to have different interpretation of your of your causal parameter, because the causal parameter is actually say like the average effects is actually defined from with the assumption that you are actually comparing everyone in your sample to be treated versus everyone in your sample to be receiving control. But who is in your sample is actually relevant, and it's also like is the intervention or exposure relevant to everyone in the study population? If the intervention of interest actually might only be adopted by a small number of individuals targeted to a certain sort of subgroup, partly because of cost, or maybe because just the interventions only make sense for some subpopulation, then you actually want to focus on your estimation just on those subpopulation, right? Yeah, and also like, will there be like, do you want to sort of generalize your finding? Yeah, or compare with different studies. I think comparison with different studies also are like a big problem now, because I guess people a lot of times using data from different sources. They could be rich data, but they could be data that has like consists of very different people. So what we, I mean, so when we compare results, sometimes the results actually could have some, you could have contradictory result, not because of the causal mechanism or it's a problem with assumptions, but it could just be because you have different study population. So we are going to sort of look at an example like that in detail. And then, yeah, I guess fair comparison is one thing that we have to always think about, because that makes things, I guess, when we want to talk about sort of things, the causal relationship between the an intervention and a control, you always want to make sure your comparison is fair in some sense. So in what sense, would that comparison be fair? So those are sort of like questions that we want to ask ourselves first, before we dive into anything, more, I guess, more technical. So I'll give a brief, I guess, introduction to confounding. This is, I guess, a textbook definition, like what a confounder is, say from a intro API classes. Like confounders are variables that are associated with the prime exposure and outcome. So I mean, well, here in this short course, sometimes we'll use exposure, and then I sometimes talk about intervention. I'll actually use them interchangeably. So treatment, exposure, interventions, they mean this like a similar thing. It's basically like this is the cause, and then the outcome is the effect that you want to sort of establish. Like whether like with the exposure could be like smoking, right? So you want to compare smokers, non-smokers. It could be like a certain intervention, say maybe a job, like a say job training, for example. Like so I'll usually denote the exposure by Z, and then outcome by Y, and then the confounders by X. So the confounders needs to be associated with both the exposure and the outcome. So then we call it like this as like the confounding problem. So if one of the two arrows, so the arrows from X to Z are absent, so in these situations, in the situations below, if we don't have, so arrow represents like, well, roughly association, but I guess if we use the directed edge, basically we want to say this is sort of I guess that happens like before basically the exposure. So the confounders are actually variables that are thing is like pre-treatment. So before the exposure, before like it's defined, say before it's actually exposure takes place. So if there's no arrows from one of the two possible arrows from confounder to exposure, or the outcome, then there's no confounding. Okay. So and in most of the situation in observational studies, because you're not you don't control who gets the exposure, right? So the exposure would then be affected by some different So it could be individual characteristics, or could be like, you know, some like, let's say like, you know, age, gender, education, like so some you know, baseline, so demographics, but it could also be like affected by, say, maybe environmental, also other sort of factors. Okay, so you know, in this case, then usually we would have, you know, in observational studies, we will have this kind of relationship where like there are variables that are related to both the primary exposure and outcome of interest. If you sort of look at this, well, I guess some of this, you know, may or may not be sort of, you may or may not easily find an example for these three stuff graphs, but the left ones actually, if you have a certain way to break the length between the confounders and the exposure, then you don't have confounding. So this is actually the case under randomized trials. So so if you can somehow randomize the exposure, then the exposure will maybe related to the outcome, and then the outcome might be related to, you know, personal other characteristics, but then you, because of the randomization of the exposure, then you don't have a relationship between those you know, baseline characteristics with the exposure. So we're going to look at this, you know, in more detail. The confounding adjustment is one thing, of course, like you want to do, like you have confounder, then you want to adjust for confounding, right? So I want to sort of briefly tell you there are actually two ways of confounding adjustment, two some major ways of confounding adjustment that you actually can read from this sort of simple graphical sort of illustration. So the first one, well, again, it is related to like the fact that you have sub two arrows, one from X to Z. So from the confounders to the exposure, one from the confounders to the outcome. Sorry, I need to go back to, oh, sorry. Okay, so this is the right slide. Okay, so this is the usual confounding adjustment that you probably learn from regression class. And maybe from the first course in NAPI. So it's that you use regression, so you regress your outcome of interest on the exposure and also the confounders. So you control for X by regression. So in this case, then Y is the dependent variable, well, in the regression model, and both Z and X, so Z is the exposure, X is the confounders, both of them would be independent variables that you put in, you know, in a regression model. Okay, so that's easy. You can, so if you get the data sets that you have your outcome of interest, your exposure of interest, your and confounders, then you can just put your outcome as the dependent variable, and then your exposure and also the confounders to be say independent variables. Right. So in this procedure, you actually are modeling these two arrows, right? So how Z and X are related to Y. And you do not model the relationship between X and Z. So I put a dotted arrow here, even like it, I mean, it exists, you know, in the confounding situation, but you don't have to model it. Well, for statistics students, then you probably know the reason is because if you factor the likelihood of like all the free variables, then you basically can factor out the likelihood of Z given X, right? So then we can basically say that the likelihood based on z given x is ignorable. And then if we only want to know about, say, this arrow, right? Well, so that's easy, right? You only need to deal with so y given x and z, and then you don't have to deal with or you don't have to model. I mean, it is there, but you don't have to you know, care about it. And then this is sort of the usual sort of procedure, but I guess some people find it, and it is basically used, you know, it's a lot up to maybe 80s or 90s. Basically, this is like the way that people have been doing like confounding adjustment. But then people raise question about this kind of procedure because if you have a lot of confounders, then modeling this procedure exactly is kind of difficult because there could be nonlinearity, interactions, etc. So, I mean, yeah, it's just hard to sort of specify the you know, the correct model, and sometimes model diagnostic is also not easy. And also the interpretation of the regression coefficients, it has a conditional interpretation, which basically is like, you know, you have odds ratio, you have like risk difference, you have like risk ratio type of, you know, subparameter interpretation, but it's all conditioned on X, which sometimes may be a little bit hard to you know, interpret and compare. So say if you have two studies, one study have say 5 confounded, like the model compare, like, you know, well, have include 5 confounders, another include 10, and then you're running a logistic regression. And then, well, within each study, you can basically say that, well, the parameter of would be like loss of rate, log odds ratio of the exposed versus the unexposed, given like the confounders that is being controlled for. But depends on the number of confounders that's controlled for, that actually the parameter actually changes. So if you, even without confounding, this is probably something surprising to some of us, but if you actually add different sets of you know, X, then you actually will you will change the parameter, you know, of interest, which actually is this parameter. So this is one problem, like, you know, say comparing across studies, sometimes, I mean, might be a little bit different, and also because of this sorry, I don't know why, maybe I can make this okay. So the conditional interpretation itself has some shortcomings that people actually sometimes would feel a little bit difficult to interpret. Okay, so an alternative strategy is like general strategies to use propensity score. Propensity score actually involves modeling the other you know, pathway that we do not model in usual regression model, but we leave this sort of direct relationship between the confounder and the Y to be usually not to be modeled. So if you compare with like the regression adjustment sort of models, whatever is say X and both X and Z, whatever independent variables are related to the outcomes. So the propensity score is actually do a difference. So that the target of the model is actually different. right? So you are modeling the selection probability. So which basically is how the exposures actually change given different values of the confounders. And you don't model directly the relationship of X and Y, which sometimes is difficult. Well, of course, you then can say that, well, it's difficult to model X to Y. It's also difficult to model X to Z, right? So what's the point? I guess the point that you're going to see is actually it implies like modeling this this direction, even though it is hard, still hard. If you have a lot of confounders, it implies ways to check balance. So it actually gives you some sort of qualitative ways to actually make sure that your comparison groups, like how comparable your comparisons groups are. So it is for easier model diagnostics, basically. So that's why, like, this is one reason why people like this kind of modeling, because you are going to, well, you don't need to correctly specify this model, but you can still get good balance. So this is something sometimes nice, and also it separates the some modeling of the design mechanism, or you know, and the outcome, which also has some added advantage. And then the estimates that we use in this process usually will have a marginal interpretation, because you don't because you are actually looking at how the marginal change in Z system, if it would affect the outcome. So you're not, because you don't directly model how X is related to Y, then actually you don't have to consider that in your modeling, and then your estimates actually have a marginal interpretation that some people think that it is a better interpretation. But we'll see. Like we are going to dig deeper into this. Okay, so I guess this is just some very brief overview of you know, there are basically two main strategies in dealing with confounding, because a confounder, a confounder needs to satisfy this you know, relationship where you have you know, the confounder is related to both exposure and outcome. So one way to adjust for confounder is actually to model this component, which is the like confounder outcome relationship. And the other way to adjust for confounding is actually to model the confounder exposure relationship, which would basically gives you two sort of broad classes of methods. So I'm going to stop here first, just for questions. Yeah. Anyone have questions? So I'm going to so have sort of two sections, right? So the first section is I'll focus more on the former strategy, and then like the and the second section I'll focus more on propensity score. But before, so it just gives you a very like general impression, right? There are two like major ways, because like, you know, there's basically different ways you could use the model. But then we, before going to sort of the details, let's sort of look at this like a different set of questions. Now we focus on the sort of causal definition, so the parameters of interest. So what do we mean by sort of a causal or causal comparison, or what do they actually mean by average treatment effects. So usually, like, well, again, this looks fictional, but this is sort of like the thought experiment that people often use and sort of inspired to to define potential outcomes. So suppose we have two parallel universe and the same group of individuals live in the same environment. So, in one universe, you offer everyone, like the group of individuals, the exposure treatments, but in the other universe, the same group of people are all unexposed. So the only thing that is different is the exposure, and then because they are the same group of people under the same environment, so every other things would be the same. But because you have sort of two copies of the same individual, then you collect the health outcome of interest from the two copies, and then you basically get what happens if the person is exposed, and then what happens if the person is unexposed. Then you can compare them, and also you can basically just find like the difference or any difference, because you are doing, at least in this part experiments, you are controlling every other factors than just allowing the exposure to be sort of different. Then if you find a difference, then it should be causal, and it should be it should be an effect of the difference in the exposure. So that's sort of this is sort of the thinking. Of course, you can think this is sort of like an experimentalist. If you can really do experiments on people, and you can sort of control the experimental condition. This is like done in, maybe like, say lab work, but of course in sort of population studies we cannot do that, but we still want to use this kinds of concepts to sort of define our causal parameter of interest. So if we just formalize it a little bit, we can actually define what we call potential outcomes or counterfactual outcomes, Y0, Y1, defined on the same individual. And then so this pair of quantities, so this pair of potential outcomes, so it's not estimate yet. So it's basically just a pair of potential outcome cannot be both observed in practice, because in practice you only observe one set of the two potential outcomes. But anyway, in this thought experiments, if you can collect sort of, what happens to an individual if they don't get a treatment, and what happens if they get a treatment, both in the same study, then on the same individual, you can define this potential outcome. Then you can actually look at, say, effects for one individual is just the change or the difference in the outcome, and then the average treatment effects would just be the expectation or the average of the difference, in the potential outcomes, right? So, as I have alluded, this is a fair comparison because you are comparing the same sets of individual, right? So this is then the so it compares the effect of treatment for a study population, but of course with an assumption that you can randomize everyone to treatment and control, and then you basically just want to compare the average difference in the outcome. If everyone are assigned treatment to if everyone is assigned control. So this is actually the way, like, average treatment effect for the parameter of interest is being defined. But of course, like, how to estimate it is a little bit more of sort of complicated issue that we are going to spend time on, but this is sort of the hypothetical setting. So under this hypothetical setting, if we can observe both potential outcomes from each individual, then we can look at the causal effect for each individual, and then we can also look at the causal effect of the average. So this will be easy if you can observe, like, two potential outcomes from each individual, but of course this is not the case in practice. So in practice, you cannot observe both in the same group of individuals, but you actually can only observe one. For example, if someone actually take the treatment, then you observe Y1, but Y0 is missing. If someone is unexposed or takes control, then Y0 is observed, Y1 is missing. And the Y that we observe in an observational data is actually a combination of some Y1 and Y0. So this is the observed Y. Sometimes we write it as the Y of capital Z. Z is the random variable denoting treatment controls. I mean, you can write in this way, which is a little bit funny, but this basically just say that it is Y1. I just write these two sentences into just one some mathematical expression. So the data that you observe in practice is like this. So if someone is unexposed, you observe Y0, but not Y1. If someone is exposed, you observe Y1, but not Y0. So everyone, you only observe one of the two potential outcomes, but not both. And then you cannot compute the difference, individual difference. But you can still take the average of the observed Y0 and the observed Y1. It just takes the average of whatever is not missing, and then compute the difference. So you can still compute the difference. The difference is not from comparing the same individual, but it's actually compare across individuals. And you see that actually these two, when you compute this average, you use different subjects than when you compute the other average. So this runs you into a risk that if these two, sets of individuals are different systematically, then you actually would get an estimate that would be problematic or would be non-causal. So this is sort of the dilemma. We could, if we have the ideal situation, we observe everyone, both the potential outcomes, things are just easy. But then in practice, you don't. So this is you can think it's a big missing data problem in a way that you actually cannot compare the same individual. You have to compare across different groups of individuals. Okay, so if the assignment is like this, and then but this is just an example. It's from exactly the previous table, as if we observe both, but then if I just review one of them in this certain way, I'll get an estimate of difference, which is close to what we have before. But if Z is actually reviewed in a different way, then you actually, again, like the potential outcomes actually are the same, but Z is now different. So the potential outcomes are reviewed differently. Then you actually can get a difference that is, quite different from what you would have observed if you are able to observe both, so both potential outcomes. So this is a problem, right? In observational data, because you just can't observe both potential outcomes, and then you can't compare the same group of individuals. In this case, I actually add a confounder here. You will actually see that in general, so the confounder x equals to 0, then actually y are in general smaller than this group of individuals. So if you and then treatment is more common in x equals to 1 than x equals to 0. So in this case, like, this is a confounder because this relates to y and this relates to z. So in this case, you actually can see that there's a confounding problem, and then you actually will get the difference will actually not be what we want. Yeah, so speaking about, like, the lack of confounding, so we just first look at randomized trial, and this actually, well, if you sort of look at these two tables, they are actually, I got them from the same sort of hypothetical table that you observe both, right? But then it just depends on how you review the treatment. You actually are going to get like different answers. You review in a certain way, it actually will give you estimates that's quite close to what you are getting if you actually observe both. So this is actually under the case when you have a randomized trial. And suppose you flip a coin, randomly assign, well, just give a little bit context. Say, for example, like surgery on low back pain. So surgery would be the exposure, surgery or no surgery, and then like the pain score would be the outcome. So we flip a coin, randomly assign surgery, non-surgery to subjects. So we can only see half of what we would like to see in that potential outcome table. But the comparison of the surgical to the non-surgical subjects is still unbiased. So randomization actually removes action bias. So this is like this first table that we show. So to sort of look at why this is the case, well, so we have the average treatment effect. Sometimes this is also called ACE, average causal effect. But yeah, I use ATE more often. Just as a just as a description. So this is the difference of the expected y1 minus expected y0. Right, so we cannot directly estimate them because of the missing data that we cannot observe both y0 and y1. Then we kind of use this estimate, which is the mean difference, which is the expectation of y given z equals to 1. So among those people who have sub-assigned treatments, you estimate, or you basically look at the mean of the outcome, and then among people who are unexposed, you look at the mean of the outcome. So those are different sets of people, right? Because it's like you either have z equals to 1 or z equals 0, so they are mutually exclusive events, right? So this is what you can do with the data. So we want to see whether this is actually the same as this. So it is. If it is the same, then we are done. Then we can say that theoretically we can just look at the mean difference, from the observed data, that it will, it will estimate the causal parameter of interest? The answer here, the short answer is yes. Well, this is a little derivation, but basically the key is that randomization actually will give us like this condition where Z, which is the treatment assignment, would be statistically independent of the two potential outcomes. So two potential outcomes can be correlated in arbitrary ways. Doesn't really matter. You can also put like X here because you know because you can have X that points to Y, but randomization is so powerful in the sense that it is, because you flip a coin to get Z, it is independent of everything that is defined. That is already defined. So it will be independent of the potential outcomes, but it will also be independent of all the like all other variables. And then we can basically write things out that this left-hand side is what we call the causal parameter of interest. The right-hand side is that we cannot directly estimate because of the missing data problem. The right-hand side is from observed data. Then we can basically estimate them because it is from observed data. So this is sometimes called identification. Basically, we say that there's something that you cannot estimate directly. You can write it in a different way, and then you can use this expression, you know, to estimate what you really want. Okay. So this is basically just to say that, well, under randomization, you have these two being the same quantity. So this is basically a nice result, saying that you can just use the mean difference, or you can, the mean difference is just the same as you run a regression of Y given, like linear regression of Y given Z, and then look at the coefficient, right? So this would give you the causal parameter or the causal estimate of interest. So this one interesting point, you know, for some of you who is interested, is that the observed Y actually and Z are actually correlated. It is just the potential Y and the Z that are independent. So this is actually something, you know, theoretically interesting, because if you don't introduce potential outcomes, then you actually cannot talk about no confounding easily. Yeah. So this is because your outcome and your exposure will be correlated if there is a treatment effect, even if the treatment is randomly assigned. But if you look at the potential outcomes, then you can actually treat potential outcome as something already fixed before, you know, treatment, and then the treatment is actually only used to reveal the potential outcome. So this is one interesting point for some of you. Okay, so sorry, okay, here. So for observational studies, then suppose we are again interested in the same thing, effect on surgery for low back pain, but we only get surgery records from electronic medical records. So then the question that would be, what leads some subjects to get treatment? Right? So doctors don't randomly assign people to treatment, right? You don't want them to randomly assign. So treatment is actually based on some, you know, information. So suppose there's a severity score, like 0 is less severe, 1 is more severe, then maybe like surgery would be assigned to more often to the more severe individuals. So in this case, we can basically, what we do is to stratify by the severity score, and then to look at the mean difference across the two groups. So if you just take the mean of everyone, compare the mean, then you get into this confounding problem, and you actually see that your Y1 is actually more than Y0. So you say if Y is pain score, then you basically would conclude that having the surgery is actually is associated with more pain. But if you stratify by the severity score, then you actually would still see that surgery is actually reducing pain within like the subgroups. So how do we evaluate observational studies? Well, we call the under randomization. We have the treatment assignments is independent of the two potential outcomes. So formal definition, we actually need the definition of no unmeasured confounding in order to sort of make cautious statement. So the definition of no unmeasured confounding is actually given here. It's actually is equivalent to stratified randomization. So it is that under each stratum defined by the confounders, then the treatment assignment is independent of the potential outcomes. So this is the formal definition of no unmeasured confounding. So using this potential outcome framework, and it is, well, first of all, like if you compare to like just randomization, this, I mean, people often argue that this is weaker because you are only looking at, say, within each strata than this holds, but it will still, you still have to assume that after you control for enough confounding, there is something close to randomness, or basically the assignments after you sort of control for the confounders, the assignment would be independent of the potential outcomes. Well, under this assumption, then the so conditional expectation of the potential outcome given X would just be the conditional expectation of the observed outcome given Z equals to whatever, like terminal control and X. So in this case, I mean, again, like this reduce you to sort of the usual regression framework. So that's why I guess this is just so matching what you expect in a sense, and also this is like, I guess, consistent with what you learned before, basically saying that if you adjust for enough confounders, then you can basically use regression model to make causal statement, because under these assumptions, which is no unmeasured confounding, then the regression functions actually would be the same as the potential outcomes given the confounder. Right. So yeah, I've just gone through this point. Then the thing here is that if we want to estimate the marginal sort of the expectation of just a Y1 or expectation of Y0, then you cannot just use the observed treated or observed control, because they are no longer equivalent under this assumption. They are equivalent under complete randomization, but they are not equivalent under this assumption. So we need to do a little bit more work. But but because we have this relationship, that we actually can write this expectation of the potential outcomes into a double expectation. So now, I'm going to, I mean, this is just a sort of mathematical notations, but this actually mean, what this actually mean is that like the inner expectation is actually regression functions. The outer expectation is to average over the covariate distribution. So then the counterfactual mean, like the interpretation of this formula is just the counterfactual mean is an average of the regression prediction, which is average over the covariate distribution or the confounder distribution. So just some connections between what you learned and what we have just talked about. Suppose we have a linear regression model, then well, so which looks at like this. You have an outcome Y, and then you have exposure Z, confounder X, no interaction. And then the average treatment effects that you could so from the formula in the previous slide is exactly beta Z, which is the so model parameter in the linear regression model. Okay, so then when you are actually fitting a linear regression model without interaction, then your regression parameter is the same as the ATE, which is nice. But this only holds for like linear regression without interaction. So suppose we have interactions, so just still linear regression with interactions, then the average treatment effects actually is not will be related to the regression parameters in this way. You can see that the ATE actually not only depends on regression coefficients, but also on population structure, just like mean of X. So if you have two samples, one, say if X is age, and then you have two samples where one sample like is you oversample younger age, and then the other sample you oversample older age, then if some age is also like related to the outcome with like the interactions with the treatment, then your average treatment, well, your coefficients will be the same in the two samples because they are both like regression models. Your coefficient, but then your average treatment effect will be different because you will have a different expectation of rates. Okay, so this is an example showing that the ATE actually does not only depends on regression coefficients, but on population structure. Right? And the ATE is different for two populations, even if the regression coefficients are the same. But we have binary outcomes or like outcomes that are more complicated, then well, we can still use a GLM for sort of conditional effects, but the average treatment effects now looks very funny. It's complicated, but it is still like an average of some functions of the covariate distribution. Well, this looks terrible, but is there a way actually to sort of converge like the sort of the conditional effects to marginal effects, or how do we calculate for general models? There is a recipe, and there is a methods which we call predictive margin. But they have different names to this. Sometimes it's just called marginal effects. Some it's also called recycle prediction. Sometimes, but you often like will see like people describing this method have a prediction or name and then a margin. So this is, well, yeah, at least I like to call this a predictive margin, and so it matches with some statistical literature. So what you do is basically fit any regression model by given Z and X. It could actually be like just GLM. It actually could be machine learning models. Anything like any models that actually can give you a prediction of Y given the exposure and the confounders. Then you calculate 2 predictions for each subject using subject-specific covariates xi. So each subject you will have a covariate or set of confounders, and then you use this xi for an individual and z equals to 1 to predict a potential outcome of 1 for that individual. And then you also use the same covariates, but then set z equals to 0, and then you predict and give another prediction. So each subject you have 2 predictions, and then you average these 2 predictions across all subjects, which will actually gives you an estimate of, so the expectation of the potential outcomes. And of course, then you can sort of calculate the difference of the 2 counterfactual means as an estimate of the ATE. So, I mean, this process in some sense mimics like the potential outcome, or you can basically just think it is kind of like an imputation kind of procedure, right? So you're basically making a prediction of Y1 for each individual, and then you're making a prediction for Y0 for each individual using the confounders, and also by setting the exposed, the person exposed and to non-exposed. Then you basically get 2 predictions for each individual, and then you can basically just average over the entire data set. So this is like the way which is done. Okay. So, well, pros and cons of this method. First of all, it's quite easy to implement, and it's also can be applied to sort of general outcome data. And it is also consistent with the regression model that you would like to fit, which is nice, because a lot of times you are fitting like conditional models anyway. That you say if you fit a conditional model and then you want to also sort of presents like a marginal results in the same paper, then people don't have to fix multiple models. But of course, it's also have a certain disadvantage is that the conditional models is actually hard to diagnose, and the model has to fit well for both the treated and control. Sometimes if you only have you have much fewer treated than controls, that it is then quite difficult to fit the conditional. Well, at least the 2 conditional mean model, the precision of the fitting it could be quite different. And so of course, like another potential problem is that people actually can refit model until they have like whatever result they want. Sometimes, particularly for outcome like like medical expenditure, like things like skewed outcomes, you fit different regression model, you can actually get quite different prediction. And sometimes like the difference is so at least like practically you will see, well, the difference is quite large, and you don't really know which model to choose. Okay. And some more, I guess, comparisons of the marginal and the conditional causal effects. So the marginal effect is basically just the ATE defined by the difference of the average of the potential outcomes, right? So when it is just the average of counterfactuals, you don't really, the parameter is conceptually defined without model assumption, but the estimation requires additional modeling. Right? Conditional effects, on the other hand, is model dependent. It depends on length function. It depends on what variables are being controlled, or and how, whether there's interactions, blah blah blah. So conditional effects is, yeah. So it's really like the regression parameters. So it's the interpretation depends on like a number of factors. So then some people will then say that, well, then the marginal causal effect is a little bit more transparent. I mean, if you compare in these terms, right? However, the marginal causal effects is population dependent. Population with different substructure will have different AT, right? So this is a bit of a problem if you want to sort of transport the result or compare results, say in a meta-analysis or things like that. So if you actually look at meta-analysis literature, people mostly just look at conditional effects, because the conditional effect would remain the same if some part of the population is under or oversampled, right? So then people might think this is more transportable, while the marginal effects actually depends on which part of the population is under or oversamples, because it's just like a sort of average. Of course, there is a fix, but the fix is usually people don't do that. But you could is basically do some kind of survey weighting or risk adjustment to basically, yeah, you have to represent your sample to like a target population, and then if you have different studies and you can obtain all the data, and then you can do this standardization procedure, of course you can still compare the estimates, but then there'll be more work. So well, I'll stop here for a bit. Any questions? Any questions in the chat, or let's see.
Gary, you're just so clear, There's no questions because you're explaining so clearly.
Hey, thank you, Ruth. So
I have a question.
Sure. Yes.
Sorry, Ruth. This is Amalia. I'm kind of just getting into this area. There's the caveat. When you say the marginal model is the marginal models are the ones where you estimate it separately you estimate the risk of outcome in the exposed and in the unexposed. Is that right?
Mm-hmm.
And so do you, sorry, naive question. So do you get two sets of coefficients for all your exposures then? Okay,
so there are different ways people could do that. One way is actually you fit the among the exposed, and among the unexposed. So you get two sets, but of course you can also build a model. But I think a lot of times people will, people will try to build a rich model, so they will include like interactions and things like that. Yeah. So I guess if you include enough interaction, it is sort of like you are stratifying on the exposed and unexposed. Yeah. So I guess, but well, this is something that is also related to sometimes say when you fit certain model like the medical expenditure, I guess, yeah, when you actually do it differently, whether you stratify and then or whether you sort of put whatever number of interactions in it, you can actually get pretty different results. I guess that's also like the problem with this method. Yeah.
Thank you.
Gary, can I just ask you before you go on to make clear the circumstances again under which the predictive marginal effect is a causal effect? Because when I teach it as a device for getting a marginal effect. I stress that it's not causal. And then I say, if we want to do causal, then we go on to do things like, other like propensity scores. But from what you're saying is you kind of are teaching it as causal, but the conditions are very specific. First, no non-observed confounders, but also your model has to be correctly specified. What are the specific conditions under which this predictive marginal estimator is causal?
Yeah, so actually, Ruth, you already answered your question. It is like non-measured confounding, and also like the model is correctly specified. Yes, but I guess it's that if you only look at the structural assumption, which is non-measured confounder, it is the same as the propensity score. So the non-measured confounder is the same assumption. But is the additional piece is that they use a different modeling strategy. So I guess that's I think that's the main difference. But the non-measured confounder is the same. So under non-measured confounder, you can do predictive margin to actually get causal. Well, at least the target is the same. But you're right. I mean, well. I guess people sometimes use predictive margin, or actually even like propensity score. You can do it. It's just kind of a weighting or direct adjustment type of procedure, right? So it could be causal or non-causal. You can basically you just want to standardize it to a certain or you can say the predictive margin is more like you want to average over some covariate distribution, right? So if you average, you can average, but at least if you average over all the confounders, then you have a causal interpretation. But if you don't average over all the confounders, you still get an marginal effects, but it's but then you have to be a living. Well, but I guess it is still a valid marginal effect, but it doesn't have the causal thing in it. Yeah.
Okay, thanks.
Great. Yeah, thank you. Okay, so well, I guess I have a little bit of time left for this section. I just want to show you. I mean, there is I guess this is an interesting paper that I read about, like comparing sort of randomized trial results and causal and observational studies. You can sort of briefly sort of talk about that. But first of all, like randomized trial, although is a way to sort of remove confounding, it is not, well, I guess there are like practical limitations. For example, randomized trials, a lot of times proof of concept, you actually don't want it to be, applied to general populations. So you have, all kinds of different, say, eligibility criteria, for example, and also usually you don't really have a very large trial. And there are things that you just can't randomize, and even you randomize, there could be non-compliance. So there are, I mean, you can randomize people to say take a surgery, but they don't. So yeah, there are these kinds of limitations. But then observational studies nowadays, we have more and more large data sets. It could be like cohorts, it could be the surveys, it could be EHR, right? That we actually can, analyze. So I guess people often want to compare results, but then sometimes the results are different, and then we want to reconcile. So a lot of times when results different, then people will say, oh, you must have unmeasured confounding, but sometimes it's just more than that, or actually the unmeasured confounding might not be the main contributor. It could be that the two studies ask slightly different questions, like the causal estimates could be different. It could be like they are analyzing data based on different assumptions, and also like the study population could also be different. Yeah, I will actually. This is an interesting paper. So I encourage you actually to look at it. Hernan's epidemiology paper in 2008. So they compare women's health initiative to nurse health studies. So women's health initiative has a large component, which is a randomized trial. They also have observational data, but they only look at the randomized trial component here. So, and they found that so coronary heart disease risk is higher in women assigned to hormone replacement therapy. So this is a big thing at that time, right? And then the nurse health study is a observational cohort, but then previously I've suggested that's actually hormone replacement therapy was associated with decreased coronary heart disease. So they're sort of contradictory, right? So and sort of also like it's a high profile, like public health problem. So how do we reconcile this difference? Is it just unmeasured confounding in this observational cohort? Well, I guess I can't go through every detail, but there are actually differences that the authors sort of like dissects the analysis and actually find that there are ways to sort of explain the difference and also to make the analysis of the NHS actually more like the randomized trial setting in WHI, so that the result would be more comparable. So one difference is that WHI actually use intent to treat in the analysis, so that people assigned to hormone therapy, if they don't take it or they take for a certain period, but then they don't take it later, they are basically like analyzed so using the assignments, not what they actually observe. But the NHS analysis originally, they actually use the observed or the reported use of so hormone replacement therapy. So this is one difference in the estimate or in the methods. But then there are also other differences. That's well, one is like the eligibility criteria is different, like because WHI is a trial, right? But I guess I want you actually to look at this result, which is like they actually stratify, or they sort of look at sort of different regions, and actually find that the effects of well, basically there's a heterogeneous treatment effect here. So if you actually look at just first 2 years of follow-up, you actually will see that so hormone therapy actually is increasing the risk of CRT in 2 years. But if you, so it's actually just increasing the risk when you first take the, so the therapy. But then actually the difference actually would become smaller. And also has a slightly protective effect for younger women than older women. So then this actually kind of explains the difference because WHI actually has an older population. So like the sample have more older women, And then the NHS are sort of nurse that are sort of in practice, they are, a lot of them are actually younger. So then you basically see that's because, this, effect heterogeneity, and also like WHI, I guess have a shorter follow-up, I think, also than NHS. So in this case, then basically you will see that if you have a longer follow-up and then younger people, you are more likely to actually see a protective effect. Versus if you have actually a shorter follow-up and older people, then you actually will see actually a harmful effect. So in this case, they actually conclude that, well, this unmeasured confounding is actually not really the main problem. The main problem of this discrepancy is really about other factors. It's more like the structure of your of your sample, and also the questions that is being asked, the estimates basically. So this is kind of interesting because we actually can reconcile, because a lot of times we only have observational data. I guess we just need to be a little bit more careful when we convey the results. What kind of sample we have, what and we think about, I guess one way that the authors advocates also, if you think about, we do a randomized trial, we want actually to analyze the observational study, say using intent to treat, because it will mimic more like the randomized trial. So I guess I'll give us a short summary, and then we'll then take a break. So confounders are variables that are associated with both the exposure and outcome of interest. And there are two ways to remove or adjust for confounding. One by considering the confounder exposure relationship, and the other by the confounder outcome relationship. And randomization removes confounding as the confounding exposure relationship is absent. Regression modeling identifies conditional effects when all confounders are conditioned on and the marginal parameters obtained by predictive margin, or sometimes called G formula, is basically just the average of the prediction. Yeah, and then the difference results between randomized trial observational studies may not be entirely due to unmeasured confounding, and can be attributable to different estimates, different population composition. So yeah, I'll stop here. So any question or discussion? I can stop share. Okay.
Great, thanks. So it's 10:34 right now, and sorry, if there are any questions, feel free to continue. But if there aren't any, we'll reconvene.
You can put the question in the chat, so I will look at it after I come back. Yeah,
definitely. We'll reconvene at about 10:45, and we'll start back up. So thanks, everyone.
Thanks, everyone.
Hi, all, welcome back. We're going to get started again. Looks like Gary is ready to go. So I'll turn it back over to you.
Okay, thank you, Angela. So thanks, everyone. coming back. So this I'm going to talk about propensity, mainly talk about propensity score and related methods. Let me try to, okay. Yeah. So we mentioned, in the last section, so I guess one way of problem with predictive margins sometimes, or like basically like fitting multiple models and choose the one, say, with the largest effects, sometimes called data snooping by Don Rubin. So it could outweigh its advantage to some researchers. So I guess there's a we don't really well, at least like Rubens kind of advocates the issue, like we actually don't want to sort of get into this issue. So refitting different models, choose the biggest effects, and we actually want to pick the best modeling strategy before even looking at the outcome. It's just like the culture in randomized trial. A lot of times, like we are like investigators have been blinded to sort of the results or the outcome, basically, like or the even like without seeing the outcome, we actually already choose our analysis method. So Rubin then argues that we should actually still consider designing, at least like a design aspects for observational studies, such as picking the ideal experiments that corresponds to the observational studies, hide the outcome data. I guess this is the main part, because he doesn't want things people to change or at least select of the largest effects. So don't use the outcome data in sort of trying to adjust for confounder. So I think that's why we actually look at the other arrow, like the arrow from confounder to the exposure. Right? In this case, we actually do not use the outcome data when we do this modeling or the randomization or the treatment assignment procedure, right? So yeah, so that's sort of the I guess how these concepts are being have started to grow. So propensity score is actually just the conditional probability of assigning treatment assignment given the confounders. Right? So Rosenbaum and Rubin, I think it's a 1983 papers. They sort of propose the use of this propensity score actually to remove bias in observational studies. So Rosenbaum and Rubin actually shows that no unmeasured confounding assumption that we looked at before is actually equivalent to this expression. So recall that no unmeasured confounding is basically y1, y0 conditional independent of z given order confounder. But if you replace order confounder by just the propensity score, then you actually can still, like, within each propensity score strata, you actually still have this sort of randomization type of assumption. So this is kind of nice, because propensity score is just a probability. So it's always one-dimensional and bounded between 0 and 1. So it's just a number between 0 and 1, and it is no matter how many x you start with. You can start with 5 confounders, like 10 confounders, 20 confounders. You still always get like a 1 number. And this is nice because in some sense, this is like a summary of the of all the sort of confounding process onto the onto the treatment assignment or the exposure assignment. And that's the non-measured confounding is actually equivalent to just conditioning on the propensity score. So this is a really nice property that's actually it's 40 years ago. Then it's kind of started the the development. And also, like, one implication is that the propensity score also has this property that's conditional propensity score Z and X. So okay, so this is the outside treatment, and then this is the covariate. We know that, so like in randomized trial, they are just independent because randomization is just so powerful. It is like, the assignment is independent to whatever things that happens before the assignment. So we don't have this in observational study, but if you actually conditional propensity score, you actually have this. Or if you look at each propensity score strata, then the treatment and the control should actually have similar covariate distribution. So this is an implication of the propensity score, but it is very useful because then we actually can use this for checking balance and actually to see whether the propensity score fitting is good or not. And the nice thing here is that you can do all this without reviewing the outcome data. So you fit this model, whatever, like say logistic regression, with maybe with just the main effect, maybe with interactions between some x's, whatever. But you get a propensity score, and then you actually can do this balance checking. So like until it's sometimes still you need to do refitting. This is like a slight disadvantage, but in any case, your model building actually does not use any of the outcome data. So you actually can even like just you don't even need the outcome data. So it will so the outcome data actually comes at last. So it's actually that then you only analyze the outcome data once. So I think this is sort of the philosophy behind this or some of the appealing features about this way of modeling, right? So so this is sort of like the theoretical underpinning of the propensity score. Basically two properties. One is you can replace the non-measured confounding assumption to basically just condition on the propensity score, which is one-dimensional. And then you can also you also have this balancing condition. Okay. Then there are sort of multiple propensity score methods that are proposed, because in some sense you can use it in different ways, right? So one way is basically propensity score can replace X, in the confounding process. So one way then we can think about is, well, expectation. Well, this is the ATE we want to estimate. Then we can write it in terms of, a G formula. Basically, just iterative expectation. In the last section, we look at the condition of Y given X and Z. Now you can actually put it as conditional of Y given pi X, the propensity score, right? Because of the non-measured confounding property, you actually can write in this way. So then one way, well, of course, like you can then, there are different ways to use this formula. One way is maybe you can put a your regression model with like maybe splines on the propensity score. That's like some people do, but you also can do something even simpler, is to categorize propensity score into bins, for example, quintiles, basically categories of propensity score. And then for each stratum, because this is sort of like you can look at like fix the propensity score stratum, then look at the difference in mean between the like exposed and unexposed within the stratum. Then each stratum you sort of get a sort of difference estimate, and then you average overall the stratum, which if you define the stratum just by say quintiles, then the averaging is just a simple average. Okay, so this is like what is sort of originally proposed by Rubin, because it really, I mean, if you do stratification just by one variable, it is okay. Yeah, it's easy to do stratification. If I mean, it's just like if you have multi-dimensional, like the original covariate, it is very hard to do stratification because each strata you only have very few, observations. But then after you mapping it into a one-dimensional construct, you can actually easily, and also it is between 0 and 1, so you basically can easily do so. Like look at stratum. But of course, like this is actually the oldest methods. So sometimes people still use that, but of course, like people now have more fancier methods, and I guess one of the sort of disadvantages is that okay, you do this kinds of stratification, but the strata actually does not have physical meaning, and you can also and also because the propensity score is actually estimated, so you actually can have like a misclassification in self-strata. So there are some problems associated with it, but it is kind of like the simplest way you could use propensity score. And also one thing is that if you create just a few propensity strata, then it actually, you are sort of coarsening the information in a way that you're not sort of fully using all the confounding information. Then it's actually, it reduces most bias, but it actually can have some residual bias. So people, I think, I guess this like rule of thumb is sort of like if you in some simple setting, I guess where some simulations have been done, I think when you actually have 5 or more strata, the rule of thumb is like you have 5 or more strata, you usually can sort of remove like maybe 90% bias, roughly. Then well, it's still, I mean, it is already kind of good, but I guess people just want to maybe do it better because of the residual bias. So, but how about then maybe we just create many strata with few observations in each of them? That is the concept of matching. So we actually can create match sets containing both treated and controls with very similar propensity score values. Well, overlap is a problem, but that's we're going to also talk about a little bit later. But basically, we actually need to have each propensity score strata, or in this case, matching, where you have both treatment and controls. So suppose if propensity, say for propensity score that is close to 1, a lot of times you only have the treated and then you don't have control. Because I mean, you know, for propensity score close to 1, then the probability of assigning to treatment is actually close to 1, right? So then under those circumstances, you have a lot more treatment than a control. And then likewise in the propensity score that is close to 0, you'll have a lot of controls but very few treatment. So it could be a little bit of problem in this kinds of stratification or matching, when the overlap of the covariate distribution it could be a problem. You can match case to controls. You can also match control to cases, and then there's some caveats actually, because if you only match case to control, say I have each case I match to control and then I calculate the average, you're actually estimating average treatment effect on the treated. So it is not the average. It's not ATE, but it's called ATT, which is basically the expectation of the difference of the two potential outcomes given t equals to 1, which is sometimes a good estimate by itself, particularly if you don't really have a lot of treatment, or the treatment is kind of targeted to a small smaller subpopulation. But anyway, so this is a little bit of a I guess a nuance, which is that if you just pick every treated subjects and match to a control, then the causal effect could be slightly different from ATE. But of course, you can. There are ways to actually do ATE. Basically, you have to match cases to control, and then you have to match control to cases again. So you, but you also sometimes have overlapping. Each each person will be in different match sets. So then you need to be. I guess there are ways to deal with this, in the inference part anyway. So there are many matching algorithms. That's a lot of them are kind of like optimization. Basically, it's just computation, like ways of doing matching. Which maybe say some of the maybe R or Stata, they might use different, slightly different matching algorithms. Bootstrap fails to work. You cannot actually do so bootstrapping on this problem, which is a slightly problematic sometimes. But you have an analytic variance, which is proposed by Abadi and Imbens. So this is sort of the way that most computer programs will use. Okay, but matching purposely discuss observation if you're just doing one-to-one matching. So it's or one to a fixed number of matching, then it is may not be efficient. Of course, there are ways to improve efficiency. You can match, you increase the number of matches, and then you also can match the sort of random number of but basically you can just match to every one which is close to it, so you're not discarding that many observations. Let's take a look at an example. This is a maternal smoking study, study of maternal smoking to low birth weights from singleton births in Pennsylvania. So the exposure of interest is smoking or not, is binary, and then a birth rate would be the outcome of interest. So we have less than 20% of the participants smokers during pregnancy, and then with this field covariance. I give you like a stata and R code for doing this. There are sort of like standard way of doing matching, which is kind of well, I mean that is built in the software, which actually make things simpler a lot of times. So you in stata there's a T effects, which actually is a sort of broad set of procedures that does I guess it's causal effect type of estimation. So it can do propensity score matching, weighting, and with or other actually some other things. So this is the outcome of interest. This is the propensity score model, basically. So it's a logistic regression model. This is the smoking status, which will be the exposure, which will be the dependent variable in the logistic, in the propensity score model. And these are the confounders. And then this is the outcome of interest. So you specify this, then they actually will do a matching with variable number of matches. So there are some 1-to-1 match. Some of the match sets 1-to-1. Some of the match sets actually 1-to-74. Anyway, so but then they yeah. But then they basically estimate within sort of the difference within the match sets and then average, and then this is sort of the estimate. So this is basically saying that comparing just smokers with non-smokers, smokers will have their the babies so birth weight will be like 210 grams less than those for the non-smokers group. For R, you can do this matching, use the matching library. And then, well, here I'm actually doing 1-to-1 matching. I don't know whether R can do actually 1-to-many matching. But in this case, so that's why the estimates are a little bit different. And the standard error is a little bit different. But again, like this is kind of strongly significant, showing basically that so the conclusions are similar, estimates are slightly different because of the matching procedure is slightly different. Okay, so this is matching, which is one way of using propensity score. And then there's another way of using propensity score is actually another way, which is this is a third way to express the quantity of interest into this form. So this is actually well, again, like the formula looks funny, but it basically if you look at here, the propensity score now becomes a weight to weights. Well, you have Z and then 1 minus Z weight. Basically, this term is related to the exposed group. This term is related to the unexposed. So among the exposed, you actually inverse weight each observation by 1/πx. And for the unexposed group, you inverse weight by 1/1 minus πx. So πx is basically the probability of exposed given covariance, right? And then 1 minus πx is the probability of unexposed. So basically, like you are using the for the exposed group, you are using 1/a probability of exposed. For the non-exposed group, you are using 1/the probability of non-exposed and unexposed to sort of weight your observations and then to get your estimate. Okay. So suppose like we have pi x equals to 0.2 for a certain x, and you have 100 participants with this covariate value, then on average you have 20% in the treated and 80% in the controls, right? So because this is like 0.2. So of those 20 assigned to treatment, they actually represent the original 100 people in the original population. So that each person would represent 5 individuals on average in the original population. But for the same covariate value, because you have 80 controls out of the 100 persons, so the 80 represent 100, so each person only represents 1.2 individuals in the original population. In this case, like the inverse weight is 5 for the exposed group. The weight is 1.2 in the unexposed group. But these weights are sort of multiplied to the people who actually observe to get treatment or the controls. You're basically like over-representing your observed exposed and unexposed group to represent the original the combined sample. So this is sort of the idea behind weighting. And what we do in weighting is often to treat the weights as a frequency weights. Well, there's a caveat because you actually estimate this propensity score. So there's estimation error in the propensity score. But a lot of times the estimation error isn't really that much. So compared to sort of the sampling some error of the estimates. So people don't really, I mean, there are some theoretical way to deal with it, but that is a bit complicated. So people don't usually deal with that. So they basically just view those as observed. I guess the predicted weights from the model fitting as if they are just the frequency weights. Okay, so but the problem here is that the inverse weights can actually be extreme when the propensity score is close to 0 and 1. Because if it is close to 0, you have something 1 over something very small, which is like a big number. If you have this close to 1, then this 1 minus this number is small, so you again get big weights. So the big weights can be in the treatment group or in the control group. It depends on whether there are sort of extreme weights in either direction. Okay. So this extreme weight is a problem in practice. Sometimes we're going to kind of see situations when it would becomes a little bit more problem. But the weighting is actually the concept weighting can be easy to generalize to longitudinal data with dropout censoring. So this is also like one kind of I guess area, say when you're doing GEE with say dropouts, then people a lot of times would use IPW to account for dropouts, and then the idea are kind of similar. So then people actually can sort of so that's why like these kinds of weighting is sometimes preferred because you can sort of combine the weights and things like that. Okay. So in Stata, you actually do similar things. It's actually the code is very similar to the matching. They actually just change this to IPW, which stands for inverse probability weighting. And then the other specification is the same outcome, the same exposure, same confounders. And then you will get a estimate of the sort of average treatment effects. This is similar. I mean, it's not the same as the matching estimator, but it is quite close. So then basically using weighting or using matching gives you almost identical answers. In R, you could actually, well, one way is to treat it as design weights. So you kind of create the weights, and then you basically put in, say, survey GLM. And then you basically get the estimates and the inference. Well, then the natural question you want to ask is then, well, why do you need to learn different estimators? Even within propensity score, you have like different ways of using the propensity score. They seem to be doing the same thing, right? And well, the answer is that, well, I guess there's a practical reason. Like sometimes, like reviewers might be, more familiar with one, or they have maybe a stronger, I guess, sort of experience or some like sometimes it's more like a philosophical like knowledge about like the pros and cons of the approaches. So reviewers might ask you to sort of do different, like perform the analysis in a different way in order to say at least to see whether your results changes. So this is sort of one way to sort of validate whether the results actually sensitive to some things like extreme weights. But then so you actually like at least like would actually see these kinds of requests. You do an analysis in one way, people want to see whether you get the same I guess results in a different way that targets the same thing, right? I guess most of the time you get similar results, right? So then you can just respond by, oh, we have done this other methods, using the other methods, I get the similar results, which is good. But sometimes you get different results, so you want to understand what happens. So you actually have to dig deeper. Most of the time, it's because actually your the problem is hard in a way that it will give, or the data itself actually. So it could be like confounders could have like extreme values, and also it's kind of like outliers in the confounders, and then also you could have like non-overlapping confounders. There are sort of different ways that could actually explain discrepancies of this results. So you have to do a little bit more detective work then. So in this paper, else et al. Paper, they actually compare 4 cardiovascular studies that use propensity score, your methodology, to look at different, it's different exposure, different outcome, but they want to actually show that for some of the situations, the problem is easier than in the other situation, right? So let's look at the easier problem first. The easier problem is that you actually have the red here is the exposed and the blue is the unexposed. So these two are actually kind of the easier situation where you actually can have you don't have extreme propensity score. So all the propensity score here in A is actually between 0.2 and 0.8 or 0.8 something. So and for the treatment and the control group, so they actually have quite similar propensity score distribution and without extreme weights. So this is the I guess you can say this in some sense it's ideal. Basically, whatever methods you use, you probably will get the same answer. Yeah, very similar answer. Because there's some no pathological issues, with extreme weights or like lack of overlap. So the second one is like there is just one extreme propensity score here, but otherwise it still have like good overlap and of treatment and control. In this case, usually, when you have like thousands of individuals, just one extreme propensity score usually doesn't really matter. And these two are actually the more problematic cases where you actually have some extreme propensity score and then there are poor overlap in the sense that you basically have a lot of statins, which is the exposed group. You have a lot of them have high propensity score, but like the controls have high propensity score. So when you're doing matching, then you actually can't really find good matches. Or at least you will have a lot more people in the treated group, and then only very few people in the control group to match. Likewise, it is the other way around. Basically, a lot of controls here, very few treated. And then the extreme weights also could be a problematic things when you're doing weighting. This one is the worst among the four case because you basically have more extreme weights. Yeah, so let's focus on the last study. So the one with more extreme weights and then poor overlap. You basically will see that there are some difference in the in sort of different estimation methods. If you actually look at IPW, like if you do raw IPW, the effect estimate is near zero, but if you actually like truncate large weights, you actually get a kind of significant negative effect. So even with IPW, how you deal with the weights, how you deal with those extreme weights can sort of make your conclusions different, right? So, well, I guess that this could be a problem, in practice. But this also, I guess what I want you to realize is this partly is a problem with the data itself. Because if you have a data set just like this first two studies, you're not going to get, well, first of all, you're not going to get extreme weights, so you don't have to truncate or trim or whatever. So you actually don't have these kinds of problems. Okay, so yes, so if we actually well, and then another way actually what we could look at is this kinds of plots that sort of displays the covariate imbalance in the data sets. So we usually like rank the covariate imbalance, in the original data set. So this is the unweighted data sets, and the standardized, well, absolute standardized difference is basically just a lot of times it's just the mean difference, absolute value of the mean difference between the treated and the control group of the covariates, standardized by its standard deviation. So you can basically say like, so because each covariates would have a different standard deviation, so you standardize it and they are kind of comparable in the same scale. So the I guess a certain well, first of all, you'll see that some of the distribution like H or H square here is quite basically from the exposed and unexposed, they have very different H distribution. They have also quite different like other sort of distributions, right? So zero means there's basically no difference between the two, the mean of the two covariates, among the exposed and exposed, and then the larger the absolute difference, then the larger sort of difference between the two groups. Right. So this is the the unweighted version. When you're doing matching, it depends on which variables to match. If you do exact matching and then you match on several variables, the variables that you match on will exactly have zero sort of standardized difference, because you basically just want to. But if you're doing standard matching, but I think here the matching is propensity score matching, so it is kind of nice that they are still getting pretty good. Well, I guess it's still kind of pretty good balance, if you just so yeah, if you just look at the covariate difference after matching, and then if you're doing sort of stratification on IPW, you actually would see that some of these variables start actually to have slightly less balance. This is mostly because of the this is mostly because of the extreme weights. So I guess like IPW is some more so sensitive to extreme weights. For matching, it's sometimes, well, I guess the matching is in this case, matching might be better is because you do have a lot of individuals, even though you have here you might see more treated group to controls, you still have a lot of data. So actually in this case, even you have the proportions here seems to be kind of differ quite a bit, but you still can be able to get the matches. But for the IPW, then those extreme weights here actually can make things pretty unstable. Okay, so oops, right? Yeah. And if you just look at the inverse weights, so some of the weights are so up to like a more than 1,000 or basically 1,000 to 10,000. So you know, if you just look at the you know, you basically just have like 15,000 people, but you have a weight that is for one person that is like, you know, 10,000. So I guess this is you know, for a little bit problematic.
My son might be there with me.
So, roof. Oh, okay, that's right. Okay. So well, I'll stop here for a bit. So any questions about that's the propensity score methods, and also like this yeah, so this balance of different kinds of, I guess it really depends on data set. So that is something that's you can't sometimes you really, I mean, you have a difficult data set, then you actually have to be slightly more careful. Yeah. Okay. Brian, do you have a question? No. Okay. So I'll continue. Let's look at another one. This is an analysis of the 2007-2008 NHANES data. And then the exposure of interest is the school meal program, which is national school lunch or school breakfast programs. And then we will actually want to look at the BMI at the outcomes. So we want to see whether like this school meal programs actually increase, or at least like whether there's a systematic difference in sort of BMI, mean BMI for people, you know, receiving this program. And then there's a whole bunch of covariates. So if you actually look at this analysis, if you do unweighting, so unweighted analysis, then you basically will see that those receiving the school meal, like the school meals, actually have higher BMI, which is but this is unweighted, so you can maybe like say the social economic status actually is also like related to like BMI, maybe race, right? So there are a lot of things that could sort of be you know, so confounding this relationship. But you can, and then you see that the absolute standardized difference is 1, which is kind of well, this is for the this is also average over all the confounders. But this is kind of like a big number. You see, there's basically a lot of you know, difference between the you know, students receiving the school meal program versus those do not. So if you use IPW, so then you actually get some negative results, negative estimates, which is significant. And then but then the problem here is that, okay, so there are 2 IPW that I'm doing here. One is just the usual IPW, that is by fitting a logistic regression and then just do the IPW from there. There is another IPW methods that's called CBPS, which is a covariate balance propensity score. So this is a method that is, I guess, becoming more popular. But if we use the CBPS actually have a different way than MLE to fit the logistic regression. But then after you fit the logistic regression, you still need to sort of use it for weighting or matching, whatever. So if you use IPW with the CPPS estimated weights, you still get this very similar estimate than, you know, as the MLE. And then there are other estimators. One is IPW stabilize. The stabilized estimator actually will give you an estimate that is much closer than 0 and non-significant. And then there are a few other estimators we call a calibration estimator that actually gives you estimates as almost 0. So so which results we so can we trust, or is there like a reason why we may sort of trust the one result better than the others? So of course, one way is actually to look at the covariates balancing difference. So well, without weighting, you have like huge discrepancy, but even after weighting, the IPW actually still have pretty large difference. This is actually primarily due to extreme weights in this setting. If you do a stabilized weight, it's actually lower the difference. And then if you do the if you use the calibration procedure, you actually don't the standardized difference is 0, because those procedures actually targeting on removing the balance. But then all these other procedures, they theoretically could remove balance, but in empirical data, in small sample sizes, they may not be able to remove all the self imbalance. So this procedure, so there's a type of procedure that I would talk about, is actually a procedure that empirically could remove the discrepancies. And you basically see a trend, kind of like if you have smaller sort of discrepancy between like the smaller imbalance, then your estimates would be sort of more stable, and also they are all in the range of like basically null effects. So this sort of gives you a little bit more, I guess, evidence that actually the school meal program is not going to, well, at least like the, BMI distribution is not, it's going up or down. Okay, so the calibration weighting idea is actually originates from survey sampling. So if you know survey sampling, then they use weights a lot, and the inverse probability weights actually is also coming from survey sample literature, right? It's a little bit well, the inverse probability weighting in surveys sometimes called Hoffice-Thompson, and which is like based on a paper in 1950s, right? And Thompson actually was one of the early the department chair of the Biostatistics department in this at UW. So there's some like connection, but when Thompson proposed this he used this inverse probability weighting, but I think it's before he moved to UW. So but actually this weighting type of idea actually has been, I guess, originated even before Thompson, actually Neyman, and I think like there are some papers in the 1930s that actually talks about inverse probability weighting already. Anyway, so survey samplers use a lot of inverse probability weighting. Then then they want to improve like the weights. Like one way that survey sampler to improve the weights is by external information or additional information. So the survey setting is slightly different from here, but we actually can borrow the idea because in the survey setting, it uses information available from both the sampled and non-sampled sort of individual to improve the weights. And those information sometimes, say in the survey settings, is being, I guess, it's external information from census or like American Community Survey or other kinds of large surveys. But in our case, we could actually also use this similar concepts because we have a missing data problem. As you remember, we have treated and controls, and treated only observe Y0 controls only observe Y1, but the covariates actually observed for everyone. Right? So this is the key. So you have like a smaller sample of treated, you have smaller sample of controls, but then you have a covariates that you observe for everyone. So if the weight is given, then you actually can calculate 3 different average of the covariates. So this is just by using all the covariate data, you can actually estimate the covariate average, but you can only use the case data or use the control data, the exposed data or the unexposed data to estimate the covariate distribution. And these two are inefficient because you are not using all the information, right? But these two has this weight in it. And then we also know that these 3 things are estimating the same quantity. And this is the best estimate that you can get. So the whole, I guess, idea of calibration is then to look at what discrepancy is, say, from the treated to the whole sample. You actually change the weight of the treated so that you minimize the discrepancy of the estimate. And then you also do the same thing for the control. So that is sort of, the weights that then is, constructed. Sometimes it's called calibration rate, sometimes it's called post-stratification rate, weights, because this procedure is also called post-stratification in survey sampling. But the idea is basically now we know that we can estimate, the covariates mean by 3 different quantities, and then this is the best, and then this only uses treated, this only uses controls. And then we basically just change this inverse weight to a certain weight that matches the 3 quantities. But if you just, if you do not put other, like, I guess if you just try to solve this equation, there's like infinitely many like P and Qs to sort of satisfy this, so this doesn't work. So you actually have to have an objective function, basically to, you have to start with an objective function, but then you solve a constraint optimization problem such that the constraints is given by sort of this calibration equations. Now, the objective function is one that's in survey sampling. The objective function actually is one that minimizes certain metric between the inverse probability weights with the calibration rate. So you have an objective function that minimizes the discrepancy, some kind of discrepancy metrics subject to constraints of these calibration constraints. Anyway, so this is what the idea of calibration is about. And you need to specify covariate moments, for example, like maybe just the mean and maybe like first 2 moments of the covariate distribution. There are, I guess, some, we'll talk about slightly more like machine learning methods in maybe towards the end of this. Then basically you are going to, you can actually specify maybe a larger class of moments than just like using specified moments. But I think in practice, a lot of times you can just put like maybe the mean or like first two moments, as calibration constraints. The nice thing about calibration is that you don't actually need to specify like you need to specify calibration constraint, but you do not need to explicitly specify propensity score outcome regression models or do repeating. And then this is sort of and then we basically prove that it is also semi-parametric efficient. So it has a good sort of theoretical property, and then our package with that. So I guess our package is easy to use. You can actually just look at these sort of examples. You just need to specify your outcome, your exposure, and then the covariates that you want to sort of match on. So basically, it will match on the mean of the covariates that is put here. So if you want to match some kind of cross moments, then you need to sort of specify the cross moment in the design matrix. But it will give you sort of the estimate of the counterfactual means and the difference and the standard error. So and then there's also like checking of the balance. It's like the original balance unweighted, there's some sort of unbalance, but then after calibration, because we only calibrate the mean, so I guess the balance is actually better around the middle, but there's still some residual imbalance. But usually it's not going to affect your you can actually balance maybe like higher moment in order to actually get better, but it's usually not going to improve your estimate that much. Okay, so I don't think I have time to go through another example, but the other example is basically to say that this calibration actually can be used for a little bit more complicated situation. If you have a slightly different targets than your data sets, and then you actually can do some calibration of across like different data sets. The use is as sort of like a data combination kind of techniques. Okay, yeah, I guess one thing that we actually wanted to show is basically if you are calibrating a large data set. Okay, so there are two sort of population data set that's large, and then there's a randomized data set that is from a randomized trial that is small, and then only the randomized trial has treatment, and then all three of them are controls. In some way, like one is like a control from a randomized trial, the other two is control from just general populations. And then we want to sort of combine, in some sense, like combine them in a way, or to look at basically whether we actually get the same treatment effects when we comparing the treated in the randomized trial to sort of the different control groups. The caveat is that if you do not use any weighting, the only comparison among the randomized trial will be, would be meaningful because the other control groups have very different covariate distributions. But if you control for covariate distributions in the other, or you basically make this reweights the covariates such that the covariate distribution in the other data sets matches those in the randomized data set, then you actually will get much closer estimates than. So this is basically just just using the randomized data, but then and then if you use IPW, you use unweighted. Basically, you can get very different results, but then the calibration actually would always give you result that is close to the randomized trial evaluation. Yeah, and then, but then this calibration procedure requires you to specify like low order moments of the confounders that you want to match. You can sort of hand coded things that includes like nonlinear interaction terms, but still, this is not entirely satisfactory. Of course, you can basically do say comparison like weighted distribution and things like that to basically look at whether you sort of control or you actually do like the balance is good or not. But anyway, so there are ways to sort of make it well I guess work in practice, but then people want to think about some more automatic ways. So there's like kernel machine-based methods that we all propose to actually attain approximate balance. So we only need to choose a functional space, and but we don't need to exactly say what moments we match on, but this methods, although seems automatic, it's just like other machine learning methods, they're tuning parameters. So they're also like I guess you sort of trade things off. You don't need to pre-specified moments, but then you still need to do some tuning in order to get the correct sort of balance. Anyway, so I'll skip this. I guess this is just an example showing that you have treatment control groups. If you use exact balancing of low order moments, you actually get pretty good estimates of the treated group, but then the control groups actually have quite different, could have a bit different estimates. Because the control, like the Y0 actually depends on covariance in a nonlinear fashion. Okay.
Hi, Gary.
So I guess yes.
I just want to note there's a question in the chat.
Sure.
Asking for a paper recommendation that shows how IPW can get the wrong answer, while the calibration method is more accurate.
Oh, okay. Yeah, there are. I mean, yeah, this is like GSSP paper. Our GSSP paper have actually that enhance, and the job, sort of the other sort of examples in it. So I think you could take a look at the I guess at the example section, definitely. And there are also some other work that's, I think even like there's some there's some other authors doing balancing or calibration type of methods. So I think there are also like maybe some like epidemiology papers too. Yeah, I can provide some of those references. But thanks. Yeah, thanks for asking. Yeah, this is the calibration and type of methodologies more it's under the like like covariate balancing umbrella. So it's a class of methods that I guess is sort of more recently, people have been interested in. Yeah. Right. So yeah, since that, I guess to summarize this session, so propensity score aim to create balance between treated and controls, but estimated propensity score may not have the exact balancing properties in finite sample or misspecify, because again, like this is about model misspecification. You can misspecify outcome models. You can also misspecify your propensity score. You can do model checking easier to look to sort of identify problems with your propensity score model, but this is, I guess, a lot of people has been advocating for you have to check balance, but I guess it is done more frequently, but I think people still. I mean, a lot of people still just outfit the model and then forget about whether the fitting is good or not. Calibrations offer an alternative, more direct way to match the sort of characteristics of the confounded distribution and have certain advantages to it. So it could be a little bit more automatic procedure and more sort of targeted procedure for overcoming the covariate imbalance problems. So I guess that's all from my talk, and thank you everyone for listening. Oh, I will so we'll distribute the slides to the to everyone who registered for the short course, and I think the recording will also be put on YouTube or somewhere. Yeah. Okay, thank you everyone.
Thank you, Gary.
Yeah, thanks, Gary.
Yeah, thanks, Gary. And yeah, unless anyone has any questions, we'll wrap up. Look out for an email from BIRCH. It will have the slides and a link to an evaluation. Yeah, thanks all
Hey,
for attending today.
Bye.
Good seeing everyone. Thanks, Ruth. Thanks,
Good to see you. Bye.
Bye.
Angela.
Thanks, Brian. Yeah, guess I'll see you later.
See you later. Bye-bye.
Bye.